I'll tell you a story that happened around 10 years ago, and I'll also tell you, when I tell this story to different crowds, what response I get. And the story goes as follows. I'm sitting in my office and I'm getting a phone call from the reception desk at the emergency room that an ambulance of the Red Crescent came from Ramallah to the doorstep of the hospital with a 24-year-old woman, pregnant out of wedlock, that we learned later on, with 70% third-degree burns. And I'm being asked by the receptionist, should we admit her? Because there is no burn unit in the hospital in Ramallah, there is no burn unit in all Judah and Samaria or the West Bank, 70% third-degree burns. To the physicians among you, you know exactly the prognosis. The prognosis is very, very sad. The chance to be saved is very low. It means 3 to 4 months of hospital stay in a burn unit, in the intensive care unit, many skin transplants if she will pass the initial phase. And of course, we didn't hesitate. Politics stops at the doorstep of the hospital. It was very clear that we tell this ambulance to go to a small community hospital in Ramallah. This woman would not leave, and of course we admitted her. That it goes without saying. When we took the history, the family was split. Half of the family gave the history that she got the burn because the other part of the family burned her for being pregnant out of wedlock. The other part of the family claimed that she got the burn because her boyfriend, who made her pregnant, was preparing a hand grenade against the IDF, and there was an accident, and that's how she was burned. She lost the baby during the first 24 hours. To make a long story short, she left the hospital 4 months later, scarred but alive and healthy, without saying thank you. I told this story in a Shaare Zedek dinner in London, and someone got up at this stage of the story, I'm standing now, and said, I urge you all, don't give a penny to this hospital who treats terrorists. But I'm in an LA community and I hear the oy vavoy here from the audience. And you're a very liberal community and we are very proud in this decision and what we did, although it was a very costly treatment, and of course she had no insurance, she was a Palestinian citizen, and so on and so forth. But when one talks about coexistence and hospital, these are only 2 examples out of many. You could claim that if she left without saying thank you, so where is the coexistence? Well, I believe that this woman, with all the trauma that she went through, will recognize one day the fact that we saved our life, and maybe will be grateful. You can never know. ישלח לחמך על פני המים, כי ברבות הימים תמצאנו. You can never know when you will get your return on such an investment. But yes, in a mixed city like Jerusalem, you have, you know that the Israeli population is really split between those who believe that peace will prevail one day, some of us even believe that it may happen in our days, and those who don't believe it. We believe that politics stops at the doorstep of the hospital, and we prove it, and this is our modest contribution to coexistence. Another and the last aspect of hospital life is really dealing with mass casualty events. Between the year 2000 and 2004, Jerusalem was the main victim of the Intifada, although bombs detonated in other cities in Israel. But Jerusalem was the center, and you remember, Shlomo, that I gave grand rounds in Cedar Sinai, I think in the year 2002, about the emergency management plan of Shaare Zedek to prepare for mass casualty events. Again, I will not go into that, but suffice it to say that in order to be able to stop activity, the regular activity of the hospital, upon an alert that a mass casualty event, and the definition, the textbook definition of a mass casualty event is that the resources needed in order to treat a large group of severely injured people that flood your emergency room within a short frame of time, like half an hour, overwhelm your resources. So decisions have to be accepted to stop or not to stop the routine surgical program. Blood bank, laboratories, to recruit personnel. It's a whole emergency management plan. Unfortunately, Hadassah and Shaare Zedek became the world experts on how to prepare for such an event, and unfortunately, although there was relative peace in Jerusalem since 2004, we absorbed, day before yesterday, 16 injured to Shaare Zedek. I think Hadassah had a similar number, and they all came again within half an hour, and the emergency management plan had to be activated. And we are talking here about a conventional MCE, mass casualty event. We are also prepared for chemical. At the entrance to the hospital, there is a huge decontamination center with 90 heads, shower heads, that can be activated under high pressure water in order to decontaminate victims of chemical warfare. We are in the midst of building an underground hospital, actually towards the end, again envisioned by Jack Matloff, in order to be able to protect people, especially in case of chemical warfare, because anyway the 3 lower floors out of the 10 floors of the hospital are built underground. You can see the hospital here. Our emergency room is underground here. This is the 4th floor here, from the 4 to the 10. The 3 lower floors are underground, but we are adding 120 underground beds, especially for the children's hospital that is being built here. So all in all, we are talking about the only major medical center located in the center of Jerusalem. It's 110 years old. One of the virtues of the hospital that it retains its director in 110 years. I'm only the 4th director general. But the first one was Dr. Wallach, who was brought by this group of German Jews from Germany and opened the doors of the hospital in 1902. It took them 29 years, from 1873 to 1902, to fundraise and build the facility on Jaffa Road. And Dr. Wallach ran the hospital from 1902 to 1948. But he was single and lived on the premises, which may explain his longevity on the job, And I'm the 4th Director General of the hospital, and I feel privileged to do this job for so many years, and I thank you very much for your attention.
Jonathan, I'd like just to mention the LA connection to the coexistence presentation. Jonathan mentioned...
Paul Jesser is our executive director here in LA.
Jonathan mentioned Jack Matloff a couple of times. Jack, for those of you who don't know, brought open heart surgery to LA 50 years ago, and is famous in the LA medical community for being not only a great physician, but a great humanitarian. He raised funds for the same type of department in Israel, cardiothoracic surgery unit, as he built it at Cedars-Sinai. The director of that unit, Dr. Mahir Deeb, is an Arab Israeli, and very senior position.
He's director of the chest surgery, not
the chest,
the thoracic, yeah.
A very, very outstanding physician, outstanding humanitarian, and the story about him that is, if you Google his name, you'll see in one of the terrorist attacks, a young American girl studying in yeshiva was brought into the hospital, clinically dead, I believe, was what we were told.
Yeah,
he saved her life, he brought her back to life, he nursed her back to life, he brought her back to the yeshivist community in Chicago and was a hero. So that type of coexistence can play out in a place like Shaare Zedek, and other hospitals too, obviously, but that's our story. And if you ever bump into Jack Matloff, you can thank him for not just what he's done here, but what he's done in Israel too. Because that story is a famous story and a very important story.
Yes,
fascinating speech. Just a comment about the differences between American medicine and the American medical schooling system and the Israeli medical school, and then a specific question. You spoke about how in Israel basically there's a selection process where the best and the brightest are taken, and then what you are doing is you're essentially screening for psychological characteristics. In America, it seems that the notion of diversity is more important at times than those other things. And honestly, I believe, having both observed both in medical school and also I do train residents myself, I have noticed that there has been a dilution at times of quality for the sake of diversity. And I'm not advocating not taking very compassionate people, but I'm not necessarily sure that a 47-year-old former reporter in the New York Times who wants to go to medicine is necessarily as qualified as someone who, as a young gun, who has that in their heart. The other comment I wanted to make specifically in regards to my field, the concept of brain death. The halachic literature is often at odds with the notion of brain death. And specifically, brain death as a concept originated in Harvard roughly at the same time that organ transplantation went on.
1967.
Right. And the question I have for you is, let's say someone is on a ventilator, they've had a traumatic brain injury, they have no corneal reflexes, yet halachically they still have a heartbeat, they have respiratory function. What is your approach? Can a neurosurgeon declare somebody brain dead, or is it a situation where you allow cardiac and respiratory status to stop?
First of all, most of the halachic rulers, I would say maybe excluding Rav Eliashiv, those of you who know him, recognize brain death today. And for sure, we harvest organs at Shaare Zedek. I mean, when I said that you are not supposed to withdraw life support system is when there is life. But we fully recognize, and actually I'm one of the people who spearhead this activity in Israel, being the chairman until recently. I mean, this was the term ended of the Israeli equivalent of the UNOS, United Network for Organ Sharing. We call it in Israel the Israel Transplant Center, who has the authority really to allocate organs and is promoting organ donation and signing donor cards. So of course, in Shaare Zedek, like in all hospitals in Israel, there is a committee to assess brain death. By Israeli law today, for the last 2 years, you need a confirmatory test, nothing to do with halacha. I mean, being in deep coma, having no corneal reflex, having a positive apnea test that you disconnect from the respirator for 5 minutes and there are no spontaneous respirations is not enough. You have to do either evoke potentials, BERA, or to do a TCD, transcranial Doppler. And this is done in all hospitals in Israel. And usually there are 2 physicians, 2 neurologists, or 1 neurologist, 1 internist, that undergo special training. And by law, they are not part of the ICU team and have nothing to do with the transplant team. And they are called in when a clinician suspects that someone is not only in coma, and he is not in a permanent vegetative state like our former Prime Minister, but he suspects brain death. They will come in and do according to the checklist, and once the patient is pronounced brain dead, organs will be harvested if he was a signatory in a donor card or the family agrees. And this is a big problem in Israel. And although there is a gap between supply and demand of organs in every country, I will remind you the statistics in this country, and I hope that the gastroenterologist in the audience, there is a pediatric gastroenterologist, so maybe he's not familiar, but according to the literature, right now in your country, in the US, 18,500 patients are waiting for liver transplant, many of them from chronic alcoholic liver disease, which we have much less in Israel. We have more hepatitis C. And you do around 4,500 liver transplants a year, which means that most patients waiting for liver transplant in this country are dying for lack of organs. And in Israel we have the same problem. It's much less prominent for the liver because alcohol is still not a public health problem in Israel, but it's more prominent in kidneys and much more prominent in hearts. But to answer your question, brain death is pronounced officially by a special committee in every hospital in Israel, including Shaare Zedek. The halachic aspect, so there is a very prominent halachic ruler in the Jewish community. Rav Eliashiv, who doesn't recognize brain dead. I had some correspondence with him that was not very pleasant to me. He couldn't care, I think. But still, it doesn't have any implication on our daily practice in terms of harvesting organs.